Hey guys, welcome to our lesson on EMTALA and transfers. Now, while this isn't a long lesson, the stuff in it is super important. It's simple, guys. EMTALA is the law of the land, and if we go against it, we're technically committing a crime. Now, it may not be to the level of a HIPAA violation, but if your facility is found to be violating EMTALA, someone's going to have some explaining to do. So what is EMTALA? It is the Emergency Medical Treatment and Active Labor Act. It was created in 1986 because we discovered that there were EDs all over the country that were refusing to treat patients. The biggest factor was money. Doctors and facilities were not only refusing to treat patients because they couldn't pay, but they were transferring them out if they found this info out later. Currently, EMTALA is the law for any facility that accepts Medicare payment, but it seems that it's become the standard of care for all emergency departments. So the way EMTALA works is that it requires certain things that must be done for any patient who comes through the door. The first is a medical screening exam. Now, this means that a patient can't be denied evaluation due to financial reasons. You ever wonder why the registrars come around after the patient's already been through triage and is being cared for? Well, this is why. Many facilities have decided that asking a patient about payment before they even get seen gives the impression that we might refuse to treat them. Now, while this is no longer the case, we found that it's best to get the patient in front of a nurse or a doctor before a cashier. EMTALA also says that the patient has the right to stabilization regardless of payment. We can't start coding someone and then stop because we don't take his insurance. If for some reason we need to transfer, and there are definitive guidelines for this, we need to stabilize the patient to the best of our abilities before we ship them out. Now, when it comes to transfers, we always have to weigh the risks versus the benefits. Let's take the 82-year-old trauma patient with the open compound femur fracture and the lacerated femoral artery. Your facility doesn't have ortho or vascular on hand, but the tertiary center 30 minutes away does. If he stays, he's at risk for hemorrhage, sepsis, fat emboli. A transfer would give him the higher level of care that he needs, but there's a chance he could code on the way. Risk versus benefit. Now, when we make the call to transfer, we have to meet all the requirements. The hospitals have to have a transfer agreement between them, which is basically a document that says, yeah, we'll take your patients. We need written, informed consent if possible. We can't just take an alert and oriented patient and load them in the back of an ambulance against their will. We need in writing that the accepting facility can actually take the patient and that they have a doc who will accept the care. We also need an appropriate transfer method. The back of a pickup may not be the best way to transfer a person. On the other end of the spectrum, the medevac chopper may be a bit of overkill for the stable trauma patient with the minor head bleed. On top of all this, when we transfer, we have to make sure that all of the paperwork travels with the patient. You need to make copies of everything and have a set of those copies ready for the transport team. So what's the nurse's job here? Well, the first thing is take care of the patient. Work with the team to get them as stable as possible for transport. Once you can step away, start putting the paperwork together. Now, I highly recommend that you get your unit clerk on your good side because they are pure gold in these situations. You're going to have to give report twice, at least. Once to the receiving facility, usually a nurse on the other end, and once again to the transport team. Don't assume those two will speak to each other. Make sure they both get a thorough report. If you're delegated, speak with the family. Let them know that when the transfer team gets there and where they're going. Now, one recommendation I'm going to make, don't let the family leave before the patient does. Last thing you want is for the family to be at the receiving facility waiting for their loved one who coded 2 minutes into the ride and was brought right back to your ED for further stabilization. I know they all want to beat the ambulance there, but trust me on this one. Communication is key in these situations with the patients, with family, with your team, and with the members of the receiving facility. With a true transfer, you might talk to 10 different people just to get the job done. You need to know the EMTALA laws as well as the transfer regulations in your state and your facility. And remember, the patient is the most important aspect of this case. Always make sure we're providing for their safety during the transfer process. A few key points. EMTALA is the law. Know if your facility is bound by it by Medicare or simply adopted it. Every patient gets a medical screening exam. We don't decide who to treat by the size of their wallet. When we're considering transfers, always weigh the risks versus the benefits. What's going to allow for the best outcome for the patient? Don't forget any detail with the transfer. Make sure all the paperwork is in order. You've gotten every signature and sign off, and it's all documented. Remember, as always, if it wasn't documented, it wasn't done. Okay, guys, thanks again for joining us here. Please check out our entire emergency medicine series here on nrsng.com. And as always, happy nursing.